2, 1.
Okay. Good afternoon and good evening to everyone. Welcome to our virtual case conference and bedside rounds for Southeast Asia. Again, we would like to thank you for taking the time out, considering the difference in the time, and we hope we hope that you will learn a lot from our session today. Before we formally start, I'd like to have our medical director, Asad Hafar, to give a few words. Asad?
Thank you very much, Jay. Good morning to everyone, our friends from Southeast Asia. Sorry, I have some cough a little bit. We're really very pleased to have you with us today. This is the second of our series of bedside discussion of cases. We did one 2 weeks back for the Indian subcontinent, and it was really very successful. And we hope that this one is going to be also successful. The objective is to put some light on some practices and some management aspects of hemophilia from a practical point of view. We hope that this is going to be more interactive, and we would like to have your opinion and pose a lot of questions. And I'm going to warn you, if you don't ask questions, we are going to ask you some questions. So in order to make sure that participation is maximum. Thank you very much again. And thanks for Jay and Daniela for organizing this. And thanks to our panelists, Dr. Valentino and Dr. Amy Dunn, who will be with us. So the floor is yours again, Jay.
Okay, we'd just like to formally introduce our panelists for today. The first one is Dr. Valentino from the National Hemophilia Foundation in the United States. He is the president and CEO of the National Hemophilia Foundation. Amy Dunn, a member of the WFH USA and part of the Nationwide Children's Hospital in Columbus, Ohio, also in the United States. We'd also like to thank all of you who have registered and are attending our session today, this evening, and of course our team. So that's me on the left. I'm the development and training manager, and our resident technical wizard, Daniela. What do we have on for today? So we have two case conference. We have think of it as like going to your hospital and doing our case conference. We'll have two cases presented by our panelists, interspersed with the country presentations from the different countries. If we do have time, we will have some question and answer afterwards. Just some reminders, because of the large number of participants and we want to conserve our bandwidth, we have put all of you on mute by default, but please feel free to type in your questions and comments in the Q&A box. And as Asad mentioned, we do want this session to be really interactive. So we will also, you can also use the raise hand prompt at the bottom, and we will get to your questions as soon as we can. Please take note that the cases were selected on the basis of relevance and to cover as many topics on hemophilia as possible. I'd like to reassure everybody that the order of the cases were randomly generated. Again, due to time constraints, we may limit the number of responses. But again, if there are any questions, feel free to type in your questions and we will try to answer them either during the session or even afterwards. You will probably notice that we will be having some poll questions in between the presentations. This is just to get an idea of our participants and as well to keep you engaged. In fact, we will have one of our poll questions up right now. So we'll just give you time to answer. As we can see, our early participants, there are 52, 52 already have joined the session, and 60%, around 60% have answered. Please feel free to answer. There is no penalty, or well, there's still no reward for answering. So please go ahead.
We're gonna close the question in 10 seconds.
Okay. So let's proceed with our first case, again presented by Dr. Len Valentino of the National Hemophilia Foundation in the United States.
Thank you, Jay. And thank you, Asad, for inviting me and WFH for having this case conference. So I wanted to talk to you a little bit about a boy that I saw several years ago with moderately severe hemophilia A. He had been previously diagnosed with 3% factor VIII activity. This child was part of a family with other boys with hemophilia. He had an older brother who also had moderately severe hemophilia. The family was in clinic fairly often, but really never grasped the full implications of their hemophilia. So what I mean by that is that they rarely came in for problems and only came into the clinic for comprehensive clinic visits. And so this boy presented with a painful, hard lump on the top of his head. This lump was probably about 2 centimeters in diameter. It was firm. It did not move with the scalp or the soft tissues, and it was not tender to palpation. So we were very concerned about this. On questioning the mother, she told us that this lump had been there for about 3 or 4 weeks, and it was only because of the hair loss that she brought him into the clinic, because he no longer had hair over that area. So on the next slide, you can see where the lump is, and the history that his older brother gave, who was 10 years old. He told us that this happened while the children were playing, and that he hit his head on a metal bar at a playground. And he did not cry. He did not seem injured at all. There was no change, according to the brother, in his neurological status, as well as a 10-year-old could assess that. But he continued to play and seemed to be perfectly fine. And I think there's one more slide. And here again, you can see towards the back of his head, the lump that's there. Again, firm, not tender, and not particularly troubling to him, but certainly very concerning to his mother, not because of the lump, but more because of the hair loss. So I think we have a couple questions for you to think about here. So what additional information do you need, and what else would you like to know about this child? Is there any diagnostic testing or imaging that you might request? And then how would you go about managing Carlos? So Jay, we can open it up to the group.
Yes, yes. Asad, would you like to moderate the question and answer?
Yes, please. So now, as you noticed, we need to see the more information. what would you like more to know? As you noticed, it's a case of hemophilia patients with a family history, and I'm not quite sure if our Dr. Novi from, for example, Indonesia is with us, and I know Novi is very active in this. So Novi, is there anything that you would like to ask or comment here on the first question?
Yes, thank you very much, Dr. Assad. I would like to ask how much factor VIII was given to this patient when the accident happened?
None. So he did not present to the clinic for at least 3 weeks after the incident. And as I said, his mother only brought him in because there was hair loss over the scalp. She was not at all concerned about the bump. She was more concerned about how his head looked because of the bald spot on his head. So no treatment was given for 3 weeks.
Okay, thank you. So I think I would probably ask for a CT scan.
Okay. So let me ask, what would you be looking for on a CT scan?
I'm thinking about the bleeding, probably the what do you call it?
Okay, so I can tell you that we did not do a CT scan. His neurological examination was entirely normal. He was acting normally. His appetite was good. He was playful, fully aroused. There were no neurological deficits. And we elected not to perform a CT scan.
Okay. So I was probably thinking about the subgaleal hemorrhage.
Okay, so does anybody have any other thoughts about other testing that you might do?
We have a comment from Dr. King. Maybe I can, we can ask her to talk.
I think Dr. Ayek from Myanmar also, she's commenting. So maybe if you would like to speak, please.
Yes, hello, can you hear me?
Yes.
I would like to see the scar X-ray as well to see any periosteal, subperiosteal, or hemorrhage, hematoma, or any calcification.
Yeah, so the question that we debated was whether we would do a radiograph of his skull or do an ultrasound of the head. And we elected to do a radiograph of his head. And the concern that we had was whether this hematoma, which had clearly calcified, was invading into the calvarium, into his skull, and that this could potentially result as a pseudotumor. We were fortunate to see on a radiograph that this was all in the subdural space, in the extradural space. There was no involvement of the skull bones, and it was all in the periosteal area. So it was a subperiosteal hematoma that had now calcified over 3 weeks.
Dr. Sofal from Cambodia, also from Phnom Penh, he was suggested also the ultrasound. So Sofal, would you like to comment?
Yeah, thank you, Assad. I think only ultrasound can help to identify of hematoma, and we should do test for inhibitor to factor 8 also.
Yeah. So we did not do the ultrasound, but we did test his factor 8 level, and we did look for the presence of an inhibitor, which was absent. So this boy had only been treated 3 times in his life with factor 8 replacement therapy. So we thought that the likelihood of an inhibitor, although possible, was fairly low, especially since he did not receive intensive treatment after the injury. So there was no inhibitor present, and we actually retested that about 3 months later, and there was still no inhibitor present. So we were fairly certain that there was no inhibitor, but we were still left with this calcified mass in his subperiosteum.
Yeah.
Okay.
So I think Dr. Jenny from also Davao is with us. So would you like to move to the third question? How do we go about managing Carlos?
Actually, I'm about to ask Dr. Valentino, how about the inhibitor status of the patient? And it was answered that there's the patient is negative for inhibitor. So I would like to ask regarding the number of exposure days of this patient because of the probability of developing inhibitor if I'm going to give factor concentrate to this patient. And I wonder how long will this patient respond if I'm going to give prophylactic or just 2 times a week factor 8 concentrate with this patient. Low dose, probably.
Yeah, so this boy had had 3 exposure days prior to presenting in the clinic with this mass on his head. So only 3 exposure days.
Excellent.
Yes, Asad, perhaps we can solicit opinions with regards to the third question about management.
Yeah.
Wrap up the case.
So I think we just would like to ask also Dr. Mai from Vietnam. I think Mai is present. Mai, can you hear us? Daniela, by the way, Dr. U from Myanmar, he sent a message that he cannot hear. I don't know if it's problem from his side, maybe?
Maybe needs to check the volume, but I'll send him an email.
Yes, thank you very much.
Dr. Mike, can you try to talk now, please?
Yes. Do you hear me?
Yes, we can hear you, Mike.
Yes, for managing Carlos, I think it's the first one. I would like to make the laudoprophylaxis for him. And the second one is follow for pseudo tumor. And we follow him after 1 month to 3 months. We will check CT again to see the pseudo tumor, the dimension of pseudo tumor, and decide is need surgery or not.
Okay. Yeah, so Dr. saying that she'll do watchful waiting with regards to the size and to how the pseudotumor develops.
Yeah, so that's exactly what we did. We elected not to treat this boy because the radiograph demonstrated a calcified mass. There was no evidence that there was active bleeding into this area. And we chose to monitor him and watch him. And over the course of actually a year, there was no change in the size of the mass. So I basically tried to explain to the mother that it appeared to be a big mass on a little head, and eventually it would be a little mass on a very big head, so that it would be more likely than not anything more than a cosmetic change. So we continued to monitor him. There was never development of a pseudotumor, but we were definitely concerned about that throughout his course. Because he had had no joint bleeding, really had no other tissue that was post-traumatic, we elected not to start prophylaxis in this boy, primarily because of the lack of good venous access. did not seem capable of being able to do this, as well as the fact that there was another boy in the family that also demonstrated a very mild phenotype. So we continue to watch him, and he did well with this without any factor replacement therapy. So conservative management.
Yeah.
Thank you.
Thank you.
Yes.
Maybe we can move to the next case for the sake of time.
Yes. So we'll now proceed with our cases from the different countries. Again, cases were chosen. The order has been chosen at random, but I believe we will all equally learn from all of them. So Daniela, maybe you can put up the poll first, as I give it to control to Professor Ampaiwan. Thank you. Please answer the poll, or Assad will actually call you out one by one to answer the poll personally. You know Assad, so please.
Shall I start?
Just we'll show the poll results.
Okay.
Yeah, we're waiting for everyone to respond.
I see.
Thank you.
Did you get the cue already that you have control over your slides? Did you get it already?
I think you can help me, Jay.
Okay. Okay. Just let me know whether you want to move the slide.
To move, yeah.
No problem.
I can test. I can share the share screen. Mm-hmm.
I'm going to close the question now, and I'm going to share the results with everyone.
Okay. Yes. So, yeah, from our respondents, almost 90% actually do prophylaxis regimens already. Okay, so we can proceed. Professor Ampaiwan, would you want me to move the slides for you?
Yes, please. Next, please.
Yes, please proceed. So our first presenter from Thailand, Professor Ampaiwan. Please go ahead.
You will need to move in, Jay.
I will move it for her. Yes.
Yeah.
May I have the next slide, please? Yeah. This is a five-month-old boy. Have the alteration of mental status for 1 day. On the physical examination at the outpatient clinic, this is the vital sign. We found he moderately pale, bulging of the anterior fontanelle, drowsy, but the pupil still react to light, no facial palsy. Movement by both sides are symmetry, but hyperreflexia, absence of Babinski sign and negative ankle conus. Next, please. This is the CT scan at the emergency room. Next, please. So the diagnostic test, the initial one is complete blood count. You can see that the hemoglobin is low, platelet count is high. The coagulogram APTT is prolonged. PT, TT is normal. That is 4 o'clock Friday. So we need to do the diagnostic. The prolonged APTT may be hemophilia, but A or B. Next, please. So we call the bedside mixing venous clotting time. The first tube is a blank tube, so we put the patient whole blood in it, 2 milliliters. The second tube, we already add factor VIII concentrate into the bottom of the tube, and then we add the patient blood 2 milliliter and mix it. And then we record the clotting time. The third tube, we already add factor 9 concentrate in it. So from these 3 tubes, you can see that the correction just the second one. So the patient is lacking of factor 8. He is a hemophilia. Next, please. So this one, we measure the factor after. So we treat the patient with the factor 8. So this one is our bedside mixing venous clotting time that we use it at the work when we don't have the availability of measure factor 8. Next. Okay, so the treatment, emergency breathing in the brain. So we give factor 8, 50 units to less 100%, and then to 50 every 12 hours because the factor 8 half-life is 12 hours. And we also monitor for the factor 8 after exposure of 7 days. But 1 month later, the size of the subdural hematoma increased. So this boy needs more factor. But this time, we give continuous infusion. And this one is an infusion unit. It's calculated from clearance plus body weight. And the factor 8 level, that is the one that we would like to have, it comes out to be 50 units per hour. But when we measure the factor 8 level, it's just 30. So this one, for this equation, you can calculate the clearance. Next, please. The clearance comes to 18.5. Usually, the clearance in the patient is 4 to 5 milliliter or unit per kg per hour. So we suspect this one with diagnosis of inhibitor. Next. And then we measure 2.5 unit. We test that unit and go up to 10, we test that unit. Next. So our medical plan is we go on immune tolerant therapy. And at first, the doctor in charge used the low dose regimen, 50 units per kg twice a week. Even we already have a portacat insertion. And there's a breathing is a portacat insertion site. She decided to put more a PCC. Next, please. This is the response of the factor. When we start, antibody is 10 Bethesda unit or 50 units per kg twice a week. Antibody go down and then go up here. And this one, 3.8. So we decide to change the treatment. Next, please. So we still would like to continue, but we increase the dose to be 100 units per kg 3 times per week. And then we stop the PCC because no occurrence of bleeding. Next, please. This one, you can see that antibody go down to be 0. But how can we say that is success ITI? Next, please. No antibody detected is one criteria. The second one, next. The recovery of factor 8 should be more than 66%. Next. So we keep the factor 8 750 units. That is 51.7 units per kg. We expected to have 103, but we exactly measure 97. So it means that the second criteria, factor 8 recovery, more than 66%. Third, next please. this one is a calculation. This one, I forget this one. If the patient got 103.4, this is 100% recovery. But the patient got 97. So by calculation, recovery is 93.8. So you got the second criteria of achieve ITI. And then the third one, next please. The third one, the half-life should be more than 6 hours. So we measure the factor 8 at 6 hours. It comes out to be 64%. So it means that the factor 8 half-life more than 6 hours. So we can say that this patient achieved the immune tolerance. Next. I think that's all my slide. Yeah. So I just present to you of the patient that he got antibody real quick after 7 days of exposure to factor 8. So we go on the ITI and we success the ITI a little bit, not very quick, around 2 years. After that, we continue with low dose prophylaxis. And up to now, he's okay. No antibody at all. That is our case. Thank you for your attention.
Thank you, Professor.
Thank you, Jay.
You're welcome. Asad, maybe you'd like to.
Yeah, thank you, Paiwan. Really, thank you very much. This is really a very interesting case. I mean, before we start to ask also our friends, the participants, I have 2 or 3 questions to ask you here, because you suspected the inhibitors after you did the clearance. So, I mean, for some of our friends in some of the centers, the clearance might not be, let's say, available. So what would you suggest in these cases?
So for the patient with inhibitor, you can recognize if you give the adequate amount of the factor, and then the bleeding, the occurrence of bleeding, and all the result of the bleeding is not as expected. So you think of inhibitor.
Okay, that's fine. My other point also, because you started the ITI almost after 7 or 8 days of the incident. So did you consider that these inhibitors that you saw might be transient and you could wait to see how they are going to react?
Because the inhibitor is high, it's more than 5. And then the patient has a serious bleeding. He has bleeding in the brain. Yeah, so we decided not to wait. Yeah. So in some publication, they will wait until it is really one. But in case of the serious bleeding occurrence, I think to go on ITI as early as possible, it will be more benefit to the patient. Otherwise, if he has another bleeding, he needs the recombinant factor 7A. That is more expensive than ITI.
Okay, thank you. Now, my last also question, what in your opinion could be the cause of these inhibitors? Because the child also is young. So could it be, for example, treatment with large amounts of factor concentrates that led this, or the exposure days? In your opinion, what would have caused this?
For the boy, hemophilia boy, the severe degree, they have 20 to 30% to develop antibody.
Yeah.
And then this one, we also do the genetic, the factor 8 mutation. He has inversion of intron 22. So this boy, first, he have the risk factor, serious bleeding in the brain.
Yeah.
The second, he received the high dose of factor 8 for 7 days. So he is a high-risk patient. Even at 7 days, we perform factor 8 inhibitor. We don't found. But after that, on the 9th day of exposure day, he got antibody.
Thank you very much, Ampaiwan. I'm going to ask Dr. Novi from Jakarta, because I know that Dr. Novi has also seen a lot of patients with inhibitors. In fact, we saw two patients together when I visited the center in Jakarta. And one of the patients I remember had appendicitis and then developed inhibitors. So Novi, would you ask here any questions or comments or anything from your side?
Yes, thank you, Dr. Asad. So I would like to ask Professor Ampaiwan about the ITI and using Portacat to for the access of the factor VIII. What is your experience? Do all the ITI patients should need the Portacat?
It depends on the patient. Actually, we perform Portacat insertion totally, 2 cases only, because this patient is so young, so he needs a Portacat. But the one that older than 2 or 3 years of age, we don't put the Portacat on. We just put for the few patient that is very young. The one that less than 1 year of age.
Thank you.
Thank you.
Perhaps ask Amy for her opinions, because this is about inhibitors and ITI.
Yeah, I was going, in fact, to ask Amy about that to also to give her opinion.
Thanks, Asad. I'm in agreement about your approach with Portacas. I really do try to avoid them if possible, and try very hard to do peripheral infusions. I think the placement of Portacas also exposes the children to high doses of factor and or bypassing agents, anesthesia, risks that we don't have to take unless the IV access is poor. So I'm in complete agreement with your approach to that. I'm also in agreement with starting ITI early in this patient because he was having active bleeding. And I think that there has been some more recent data that suggests that starting ITI early actually might provide you with the best results long-term. You may achieve tolerance early than waiting, as we used to do in the past. So I think you did a perfect job.
Yeah. Amy, quick questions also to you, which always we ask about inhibitors, ITI, and all this. What about using rituximab during the ITI?
The data on rituximab has been, I think, a little bit disappointing. So if you look at the RICH study, you did get patients, this was using rituximab in isolation without ITI. You did achieve some temporary tolerance in some patients, but it didn't turn out to be long-term tolerance. So rituximab and ITI together seems to work a bit better, but in many patients it does seem to be a relatively short-lived response. I reserve rituximab for those situations where I'm really in a tight place. I've got to get this inhibitor down, even for a period of time, to perhaps perform a surgical procedure or get bleeding under control. But I just don't think it's going to give a durable response in most patients.
Yeah. And Ampaiwan, do you use rituximab?
Yeah, I also have 4 cases, ITI with rituximab. I'm not so happy with that because the course is not prolonged. And right now, we don't use rituximab at all. It's more costly and it is not as promising as expected.
Yeah. I see that we have Dr. Abiera from PCMC. Hello, Dr. Abiera, how are you doing? I noticed you sent also questions. Do you have any comment on this case or a question?
Asad, we also have a question from Dr. Maria. She's raising her hand.
Okay. So maybe we can get back to Dr. Abiera. Maria, please go ahead. Can you hear us? Maybe until we get Maria, because I think Dr. Len will be leaving us soon. He has another meeting. So, Len, would you like to comment also on this from your experience in inhibitors?
Yeah. So again, regarding the use of rituximab, I have found it not to be terribly beneficial, and have had actually adverse events from rituximab in terms of decreased immunoglobulin levels and increased risk for infection, although never observed a serious infection, but have not seen durable inhibitor remission with the use of rituximab alone, or for that matter, in combination with factor VIII.
Thank you. Maria, can you now, can we have your question now?
You need to unmute yourself.
Yeah. I think
I know not, as you can see, this has stimulated a lot of discussion for everybody, but in the interest of time, maybe you can just have one more question and then we can proceed to the next case.
Dr. Jenny, I think she has a question.
So anyone who can have, who's able to unmute themselves.
Yes, yes. My question is with regards to ITI and IVIG with steroids. Do you have more experience with IVIG?
It sounds like you're using almost a Boydell type approach. I have also used that in some very recalcitrant inhibitors. I have had modest success. Probably because I'm using in those inhibitors that I've really struggled with, and we've tried conventional ITI. I have been able to get several patients tolerized, at least for a period of time, but again have found when you back off of a more intensive regimen, these really bad actor inhibitors tend to come back. So I think there's just a subset of inhibitors that no matter what you do, we seem to really struggle with.
Probably, okay, one more comment, Asad, and then.
We have some questions in the Q&A, Asad.
I saw that. So there is a question, because I know that we will need to cover this from Dr. Abiera, because we talked about inhibitors for factor VIII, but now factor IX and ITI, I know it's not very much recommended because of the allergic and anaphylactic response. But Dr. Abiera is asking about rituximab with inhibitors to factor IX in particular. So maybe Amy or Len could answer this.
Len, do you want to go first, just because I know you have to leave?
Yeah, so we had used, we had attempted ITI in several factor IX deficient patients with inhibitors, with plasma-derived factor IX, and in one case did use rituximab. There was a remission for about 2 years, but then there was recurrence of the inhibitor after about 2 years. So the other 2 patients who received ITI alone, one was successful, and at least 10 years later did not have an inhibitor. The other patient continued to have low-grade inhibitor despite immune tolerance, and we stopped because of the risk for complications. None of the 3 had a full gene deletion.
Okay. Amy?
And I have, fortunately, in my practice right now, only one patient with a high titer factor IX inhibitor. He did not have full gene deletion, so an unusual presentation. And I continue to struggle with him. We did try conventional immune tolerance, with a standard acting factor IX concentrate, and that seemed to be working. But we were really struggling with IV access. He's a little guy, just a 2-year-old. And so we put in a port, and we thought we had very nearly achieved tolerance. And then he developed a portacath infection, and his inhibitor titer went back up. We kept trying that. We couldn't save that port. We had to take it out. We cleared the infection, we thought. We put in a new port, resumed ITI. Again, we're making progress. The inhibitor titer was coming down, and then he got a second infection in the new port. Also couldn't clear it, so we ended up having to take that port out, and we never achieved tolerance in him. We had tried to move to extended half-life factor IX products as well, and he, strangely enough, did start to develop some allergic symptoms when given the extended half-life factor IX products, and he never developed anaphylaxis, but he would get kind of difficulty breathing and hives with those products. So we had to abandon that as well. So they're a really tough situation, factor IX inhibitors. And I think an area where we need to put a lot more research.
Thank you. So Assad, can we proceed to the next case?
Yes, please. Yeah, please, because we
yes.
Yeah.
So our next case is from our friends from Vietnam, Dr. Mai. I've given you control of your slides, so if you can move them by yourself, please let me know. If not, then I can move the slides for you.
Thank you. But I cannot control the screening.
I've given you control, so if you have, I can move them for you if you want, Dr. Mai. It's not the problem.
Might be better, so it's easier and faster.
Yes. I
Okay.
think, yeah.
Yes. Today I would like to introduce a patient with 24 years old with body weight 50 kilogram. He have hemophilia A severe since he was diagnosed hemophilia A severe since 3 years old, and he had episodic treatment with cryo and plasma-derived factor concentrate. He have an inhibitor since 2016 with a peak inhibitor is 150 BU, and after that it's maintained around 10 BU. In May 2018, he fell down and his right knee hit to the hard ground, and he have not any repeat treatment. For a month later, he go to hospital with a big swelling in and pain in a right leg. Here it's and with he have the my enemy with hemoglobin from 89 and 61 gram per liter, and factor 8 under 1%, and with inhibitor is 5 BU. X-ray, he has a posterior tumor due to an old fracture in right femur. Because of this, at this moment, we have not any bypass agency. We just only have a cryoprecipitate and factor 8 concentrate. So we use a high dose of factor 8 combined with tranexamic acid and paracetamol. And we also make the fixing case for prepare for surgery. And also we we try to we try to have a plasma exchange to reduce the inhibitor titer. But you can see here the peak of before the plasma exchange is 30 BU, but after three times of plasma exchange, it reduces 16 BU, so it cannot make the surgery without the bypassing. So we must waiting for the bypassing. And here you can see the stereotype he's famous after the fixing cat with pseudo tumor here. And 5 months later, we have a factor 7A, and we make a surgery for amputation the right femur in my hospital. It's a hospital around with 5 kilometers from my hospital. And the situation before surgery is stable with inhibitor is 10 BU. We prepare for factor 7A before and during surgery here. 30 minutes before surgery, we use a dose of 120 microgram of factor 7A per kilo, and every after 2 hours, it's 9 microgram per kilo, and you can see here is the time between the dose after, and it's quite from far. It's a 4 hour, 6 hour, and 4 hour, and the patient come back to my center after 20 hours after surgery, and he has a bleeding since 16 hours after surgery. When he come to my center, he has a conscious and with anemia, hemoglobin 75 gram per liter, and inhibitor is a 6 BU. His body end is swollen and have a blood oozing. We use a factor 7A microgram per kilogram every 2 hours with 5 dose, but he's still bleed, so we change to factor 7 high dose of factor 8 with bolus with the 100 IU per kilo, then continuously continuously infusion from 10 to 2 IU per kilo per hour. We combine with tranexamic acid, and the bleeding stopped at 64 hours after surgery. You can see here is here is hemoglobin, and here is hemoglobin is blue one is factor 7 factor 8 11, and here is is a dose of continuously factor 8, and we maintain from 10 to 2 IU per kilo per hour, and as a bleeding stop at 64 hours after surgery. Yeah, you can see his body end is 58 centimeters in the 5-day post operator, and the weight is 68. So after in 24 hours, so the dimension of factor of his bony end is reduced 10 milliliters after 3 days with a high dose of factor 8. and the patient discharged on the 20 day, after 20 day post-operative, and we combine with make exercise, and the total of factor 7A is 460 microgram per kilo with a 9 dose, and total factor 8 is 1,250 IU per kilo, and the patient needs nearly 2,500 milliliters of red blood cell. With this patient, here is his bone after after 6 months, and now he can move with prothese, with prothese. And with this patient, we have the lesson that is a surgery in patient with inhibitor should be prepared and monitored carefully. The time between the two dose of factor 7A is a little far, so maybe it's not enough to control the bleeding. And this patient have a high titer of factor 8 inhibitor, but his we can control bleeding by high dose of factor 8 and continuously with continuous infusion of factor 8. That's all. Thank you.
Thank you, Dr. Mai Assad. Maybe you can start with the discussion.
Mai, thank you very much for this interesting case. It's really very much illustrative. I know we have Florida, Dr. Florida with us. We haven't heard from her. So Florida, do you have any comments or questions here? Remember, you need to unmute yourself, please.
I think Professor Ampaiwan has a question. She's
okay. So let's go with Ampaiwan, and then we'll go back to Please, Ampaiwan, go ahead.
I would like to comment on this patient in the developing country.
Yes, please.
It's impossible for us to obtain enough factor 7A or APCC to use as a replacement therapy alone. So the way that we did, we do the plasma exchange 2 times of the volume, and then go on the surgery and give high dose of factor 8 as Dr. Mai did by continuous infusion, and have the wound completely healed as quick as possible within 3 to 5 days before the amnestic response of the antibody that we cannot control by the factor 8. And then we still need the factor 7A, but just a few doses as adjuvant therapy, not for the single drug. It's impossible to give factor 7A every 4 to 6 hours to control the bleeding. That is my comment. Thank you.
Thank you very much, Ampaiwan. Mai, would you like to answer, or just from your experience in this? You need to unmute yourself, please.
I usually follow the success from Dr. Ampaiwan, but for this patient, after 3 times of exchange, plasma exchange, the titer of inhibitor still is 16 BU, and we have any other bypassing. And also we have a limited of financial, so and we have also have the difficulty because the patient was surgery in other hospital, and from this hospital to my hospital is 5 kilometers, but some result the treatment from when they discharge from other to my hospital is delayed. So so this patient is bleeding because of the delay of factor 7A. And it's very lucky this patient is still respond with high dose of factor VIII.
Amy, any comment from your side?
Yes, definitely. I think this is a very, very challenging case, and I think also points out how little we know about individual patients' inhibitors and their characteristics. We do know that not all inhibitors completely neutralize factor VIII. We call those type 2 inhibitors, and in those cases, I think that factor VIII can be very, very helpful in these situations, and I wonder if that's indeed what type of inhibitor your patient had. I have also had some experience using factor VIII and Novo-7 together in patients with high titer inhibitors when you're having bad bleeding. And this, of course, has not been studied. However, if you suspect that the inhibitor that your patient has perhaps is a slower acting inhibitors. Some inhibitors are neutralizing factor VIII completely within about 15 minutes. Some inhibitors take 2 hours to neutralize factor VIII and don't always completely neutralize entirely. So if you have a suspicion that your patient does still seem to have some response to factor VIII, at least for a period of time, you could suspect that they have one of these type 2 inhibitors that has maybe a slow onset activity. And in those situations, I have used factor VIII with addition of low-dose Novo-7, 20 micrograms per kilogram, to potentiate the effect of factor VIII. And in that way, I could use lower-dose Novo-7 with the factor VIII and still get a good response. So what we really need is better ways to characterize inhibitors so that we can individualize the care of these patients. And there are certainly people around the world working on this issue. But just keep in mind that you may have at least a period of time where factor VIII is effective, and if you use in combination with low-dose Novo-7, you may be able to control bleeding sooner with lower doses of Novo-7.
Okay, thank you. There is a nice new or interesting concept here, which is the plasma exchange. And I know that some countries, they might not have this. So what would be the way to go around this? So I don't know if Taiwan, would you like to comment on this? Because that might not be available with many countries.
If we don't do the plasma exchange, it's difficult to give the factor VIII to be effective. Plasma exchange can be done using the blood bank machine. But in a country that not available for life saving, we do the whole blood, total whole blood exchange before. But this one, the total exchange, you have to remove red cell and then plasma. So you have to replace packed red cell and then plasma together. Not so convenient as the plasma exchange. Right now, they have several machines of the plasma exchange. The simple one that the nephrologists, they use it. So right now, the machine for plasma exchange is not so difficult to find. So right now, we do the plasma exchange, no more total whole blood exchange, except the patient is a young boy. That in the previous time, we do total blood exchange. But right now, because the boy is small, the bypassing agent that they need is not so high. So right now, we give bypassing agent for the young patient. The body weight is just around 10 to 15. So they don't need so high amount of bypassing agent. And for the adult, we use the plasma exchange before giving high dose of factor VIII. Thank you.
Amy, there is a question from Dr. Abiera from PCMC in Manila. And this is where resources are limited. How will you characterize inhibitors, clinically or by lab testing?
I think I would always like to do a Bethesda titer if at all possible. Certainly if not that, a mixing study. But just, I think it's important for everyone to recognize that the Bethesda titer, it tells us only one small piece of information about that inhibitor. And it really doesn't tell us anything about the kinetics of that inhibitor. And so until more specialized testing is available anywhere, and it's really only in certain research labs at this point, I think the best we can do is use our clinical judgment and follow our patients very closely as we give them different products and see what they respond to. So this is where the relationship with the patient and close observation, giving different combinations or different doses of drugs is very important. But a lot more research needs to go into this field.
Now, just maybe in the sake of time, one final question, which is now in many countries, there is no bypassing agents. So how we can go around doing some kind of conservative management without this? Any kind of advice on this, Amy? I know you're going to discuss it also in your presentation, but just because it's a question that came to us from Fleury.
Yeah, I think, you know, in any case of a patient with hemophilia that's having a bleeding episode, I think maximizing your treatments, including, you know, don't forget pressure, ice, topical treatments. Think about the use of concomitant antifibrinolytics if you have those available to you. If at all possible, develop a relationship with a surgeon who starts to understand your patients and your patient's needs if at all possible. I have found that really does help us get better results if we work with fewer specialists, because so many people have not seen or operated on a patient with hemophilia before. So I think having that open conversation between the hemophilia treater and the surgeon is also incredibly important. And then just be very diligent about wound management as well. So do everything you can in your power to have the surgery planned or the treatment for the bleeding episode planned up front so that you can minimize bleeding later on.
Okay, thank you. Jay, I think for the sake of time, we need to move, right? To the next, yeah.
Dr. Ong, I was in the Philippines last year. It was lovely.
I hope you can visit her here in Davao City, the southern part of the Philippines. Okay.
Can you control the slides, Jeannie? Just that confirm if you can.
If you visit Philippines without visiting Davao, you haven't visited. We need to go to Davao.
Okay. I don't think Jay can move. Can you do it for me?
Of course.
Yeah. It's going to cost you, Jay.
Yeah.
Extra.
Okay, go ahead, Jeannie.
Okay, so good morning and good evening, everyone. I'll be presenting J.A., 4-year-old male from Marilog District. And he was admitted last March 19 because of seizure. Next slide. He is already a diagnosed case of hemophilia A, and his condition started about 5 days prior to admission when he slipped and caused him to hit his head on the floor. There were no loss of consciousness or vomiting. No consultation was done until 1 day prior to admission when he had onset of generalized tonic-clonic seizure for 1 episode lasting for about a minute. No consultation was done until morning prior to admission. There was recurrence of seizure now occurring about 4 times lasting for a minute, 1 to 2 hours interval with noted increased sleeping time. This prompted consult and subsequent admission. Then, next. He was born to a gravida 3 para 3 25-year-old mom with no history of hemophilia in the family or other bleeding disorders. He has one younger brother and no sisters, both asymptomatic for bleeding. He was diagnosed to have severe hemophilia at 1 year old, and he had frequent bleeding. Most of the time, he was just controlled by cold compress. But he had 2 previous admissions due to hematuria and hemarthrosis. But upon review, he had already 7 exposure days before this admission. He was on on-demand treatment with factor concentrator. Sometimes he's receiving cryoprecipitate. Okay, and his father works as a farmer with a monthly income of approximately equal to $150 per month. Mom is a housewife with no other income. Okay, and upon admission, his physical examination shows normal vital signs. Okay, and next slide. As you could, what we found is that there's just a reddish to bluish discoloration for about 3 by 3 centimeter on left frontal area of the head, and all other examinations were normal except for pale palpebral conjunctiva. And his extremities were normal looking with no swelling, no deformity, no hemarthrosis at the time. So, and neuroexamination showed GCS 11 at that time, E3, B3, and M5. He was oriented to person and place, but crying most of the time. Motor response was 5/5, normal reflex, and cranial nerves were intact. Next slide. So our diagnosis, admitting impression was intracranial bleed secondary to fall and severe hemophilia A. So upon admission, we stabilized first the patient. Okay, next slide. So we gave, we requested for CBC, and the CBC showed hemoglobin of 90, the platelets was normal, increased WBC. So we started with phenytoin, and also we immediately gave the patient ceftriaxone because of increased WBC, and also gave factor VIII to 750 IU to reach a 100% activity of factor VIII. The activated partial thromboplastin time, the APTT, was 95 during that time. Okay, next. The other laboratories were normal, while chest X-ray was normal, and the cranial CT scan showed concentric hyperdense fluid collection measuring about 7 cc in the left frontoparietal convexity. There was no abnormal density changes appreciated in the brain and brainstem parenchyma. So the impression was acute subdural bleed left frontoparietal convexity. So with this, we just continue the factor VIII at 100%. And during the second hospital day, the GCS is improving, but there's again a recurrence of seizure. So we gave the diazepam and continued the phenytoin. So we requested factor VIII assay just to make sure that we get factor VIII level at least 100%. However, it was during that time that the COVID or the coronavirus and the city has this complete lockdown. So there was no public transportation. And factor assay is available only in one hospital in Davao City, where the Mindanao Hemophilia Center is located, but this is a private hospital. So we have to forego the factor VIII assay and do the APTT. So the APTT result, next slide please, was improving from 90 plus, it was now 37 seconds, and the patient was doing well, but we noted that there's persistent low in hemoglobin. Thus, we transfused the patient with PAC-RBC. Next slide. On the third hospital day, we continue to maintain the factor VIII at 500 IU every 12 hours. And basically, the patient was improving. There was no recurrence of seizures, doing well. GCS was 15, normal already. So on the next hospital day, we decided to decrease the factor VIII to 250 IU, reaching about 50 to 60% theoretically. Next slide. Okay. Next slide, Dr. J. Okay. And from the fourth hospital day up to fifth hospital day, we maintained the factor VIII to 250 IU every 12 hours. That is about 50 to 60% theoretically. And we continued that until 7th day. Even the patient was improving, and the antibiotics continued up to 7 days, as well as the anticonvulsant. So we discharged the patient on the 7th hospital day. Next slide. Next slide. With a diagnosis of acute subdural bleed, left frontoparietal area, secondary to fall, and severe hemophilia A. So our plan for this patient is to start continuous prophylactic therapy with factor VIII concentrate if WFH humanitarian aid will allow us. So considering that this is a 4-year-old severe hemophilia A with a history of recurrent bleeding and bleeding on his joint and the recent intracranial bleeding, I think it's an indication to give secondary prophylaxis. My plan is to give low dose at 15 IU per kilo, or just give 250, that's about 16 IU per kilogram, 3 times a week. But my dilemma is there's no family history of hemophilia, so no inhibitor development that I can ask from the family. What if my patient will develop inhibitor? So, thank you.
Yep. Thank you, Jeannie. Asad, I think she already the dilemmas that we need to address.
Yeah, thank you, Jeannie. Really, it's very, very good case, and we're going to talk about all this at the end. It's a very interesting case, and before we go to our to our participants, just to ask Amy if she has any comment or any question that she would like to ask to further illustrate the case.
So this is a great case, and I think it's something that all hemophilia providers will face. A patient with acute bleeding that clearly has to be treated, but how do we do that but minimize the risk of inhibitor development? And I wish I had great answers for you. I think that it is really a bit of trial and error, but I think first and foremost, you have to treat the bleed. And then if the inhibitors happen, they happen and we'll have to deal with them. But when you have a patient with a subdural bleed and seizures, you know, firstly, you must treat the bleed. And then follow very closely so that you could try to taper off factor VIII replacement and reduce the exposure as much as you can. I think that during this period of time, the other thing that I have found, or that I at least suspect is important, is the less factor VIII that infiltrates from IVs, the better off you are and the less chance of inhibitor development. So making sure you have good IV access and that that factor VIII isn't infiltrating into the sub-Q space, I think can be very helpful.
Thank you. Thank you, Amy. I know Dr. A.A. Kang also had some experience in this. So would you like to ask or comment? I'm not quite sure if you need to unmute yourself.
Hello, thank you, Asad, Jenny, and Amy. Yes, we also have how shall I say, the inhibitor development without having the exposure to factor VIII concentrate previously, and then but for us it's always been dilemma. But we I think you have seen our patients when you visited us, so we have treated the bleeds and as well as to give the INTI. And other than that, I am agreeable with the plan of Jenny. Thank you.
Yeah, thank you. Paiwan, I've got a question to you, please. In general, in developing countries with intracranial hemorrhage among hemophilia patients, is there any paper that or any statistics to show the percentage of complete recovery with complications or death? Do you have any information regarding this?
Yeah, for the bleeding in the brain, I suggest to give at least 3 months of prophylaxis because they have a higher risk to have the recurrent or the second episode of bleeding in the brain. And then that will alter the whole situation. And then for the small boy with recurrent bleeding in the brain, they will have more problem with hyperactive, and that is more difficult to control. So for me, after the one serious episode of bleeding in the brain, for the one that without antibody, I prefer to keep prophylaxis for short period or long term. It depends on the availability of the factor VIII that as such you can provide it.
Yes.
Thank you.
But
can I echo that? I agree with you completely. If you have access to continue those patients who've had bleeding on any sort of prophylactic regimen, I agree that's very important.
Yeah, I mean, yeah, in general, in our previous always workshops, we always advise our colleagues after an an intracranial hemorrhage that they need to put the patients on prophylaxis, because if he survives the first one, we are not sure that he will survive the second one. So it's better always to put people on prophylaxis. And since we have now more product to donate, then that might be the solution. But my question is, in developing countries, do we have any kind of, let's say, epidemiology study regarding the percentage of how many people will recover completely, how many will, the percentage will recover with complications or death, just for comparison in the future, or nothing happened in the past in developing countries? Because I know in developed countries, maybe it's the full recovery is quite high.
Yeah, I can give you some comment.
Yeah.
The problem is because it is developing country, and then the shortage of the factor. Some surgeons try not to operate or do anything for the patient unless it is very serious one. So you should communicate with the surgeon that if the boy is not a hemophilia, do you operate him? And if yes, for a hematologist, it is our role to prepare the patient, give enough factor, and reassure for the surgeon that they can do the surgery properly. And for the hematologist, we can provide the perfect hemostasis for them. So that's why some patients, the outcome is not good because some surgery is not be done perfectly. It's the first problem. The second problem is a lot of patients does not receive the prophylaxis after serious bleeding in the brain. So they have the recurrent. But some recurrent may be the minute one. If the severe one, they may be passed away. But if the minute one, they will have some development problem, child rearing problem. And then the parent and the doctor will just complain that the boy is very naughty, is hyperactive. Actually, they have bleeding in the brain that create some behavioral problem.
Okay, thank you. Jay, I think we need to move for the next presentation for the sake of time.
So we'll proceed with our next case by Dr. Amy Dunn. Amy, before that, we just have our a poll. Please feel free to answer again, please. Yeah, this poll is interesting. That there is no clear winner, in a manner of speaking, with regards to what the greatest challenge is. So Daniela, maybe you can close it.
Yes, I'm gonna close it. I'm gonna share the results.
Yes, so at least we have an idea that it's well distributed with regards to what we think is the greatest challenge. So I think we can go with our next case by Amy. Amy, can you confirm that you can control your slides? I've given you control.
Oh, it would also help if I unmute myself, huh? All right, let's see.
Yep, I'm waiting for you to control. Oh, I've given you control.
Okay, they don't seem to be moving.
I can do it for you. It's not a problem.
Yeah, sorry about that. It worked this morning.
Yeah. Okay.
All right, so the case I'd like to present today is a 2-year-old. You know that this 2-year-old has severe hemophilia A, and he presents to your clinic with a swollen left knee. He's currently on demand therapy, and he's had 3 previous exposures to factor VIII. You give him a dose of factor VIII, 25 units per kilogram. You send him home. The next day he returns to clinic. Mom is carrying him because his knee is more swollen and he can no longer walk. So let's talk about the potential reasons that he didn't respond to your initial treatment.
Yep. So I think we have a poll question for this, Daniela.
Are we okay, or do we wait?
No, go ahead, please.
Yeah.
So we can go ahead. Yes. Can you show them the results, please?
Yes.
Yep. So these are our results for yeah. So it's
So this is a very, very tough question, and the correct answer to this question is any of these scenarios could actually have happened. And I have actually now in 25 years of taking care of patients with hemophilia, I have now seen all 6 of those things happen with patients. So I think it's very important as a hemophilia treater for you to be thinking outside the box always. Not all swelling is bleeding, and not all bleeding is related to inhibitors, and so it's important that you follow your patients closely. In this case, because we really wanted to focus a little bit on inhibitors today, I'm going to say that the answer is that this patient has developed a factor VIII inhibitor. We know that factor VIII inhibitors are IgG antibodies. They're directed against factor VIII, but they are directed against very different parts of the factor VIII molecule. And so inhibitors and their epitope specificity is very individual for patients. We know about 30% of patients with severe hemophilia will develop these inhibitors, and a lesser percentage of patients with moderate or mild hemophilia. Some inhibitors completely neutralize factor VIII, and some only partially neutralize factor VIII. This slide I put up to remind you that while almost all inhibitors happen early in factor VIII exposures, not always early in life because it depends upon when you have access to exposures. Most inhibitors occur within the first 150 exposures, but most high titer inhibitors happen within the first 20 exposures. But now, as we have an increasingly aging hemophilia population across the world, we are seeing a second peak in inhibitors, and that happens in the older ages. So also something to keep in mind if you follow older patients with hemophilia that have done well all their life, but all of a sudden are not responding like they used to, be thinking that an inhibitor may have developed in them as well. Next slide, please. This is a cartoon of the factor VIII molecule. You can see it's made up of multiple different domains. And can people see my arrow, Jay? Can you see it?
No.
No? Okay. So this is just to illustrate with the antibodies in red that antibodies occur at different portions along the factor VIII molecule. And depending upon where they are directed, their effect on the factor VIII is also different. There are some that bind in the A2 region that interfere with 10-ase activation. There are some that bind in the A3 region and in the C2 region, and that's where factor VIII binds to phospholipid in the C2 region. And also where binding to von Willebrand factor occurs. And so depending on where your patient's antibodies are directed, you may see slightly different kinetics of those antibodies. And those, this epitope map, if you will, can also change over time. You will see with the beginning of ITI, sometimes you can eliminate one of these antibodies, but perhaps a second one still stays behind. So again, lots of more research to be done in this particular area. Next slide, please. So let's talk about some of the risk factors for inhibitor development, and many of them have already been mentioned during this presentation. Next slide. I like to think of inhibitor development that there are patient variables and then there are treatment variables. For the patient variables, clearly disease severity plays a role. The more severe the hemophilia, the more likely the patients are to develop inhibitors. Also, the mutation, incredibly important. As we are gathering more data about mutations in our patients with hemophilia around the world, we are becoming more aware of which type of mutations are more associated with inhibitor development. Race and ethnicity also certainly seem to play a role. In my population, my African American patients tend to have a higher risk of inhibitors. And then there is some thought that Hispanic ethnicity may also play a role in inhibitor development in the United States. If you have a family history of inhibitors for your patient, particularly if there's a first-degree relative, you should be on high alert for inhibitors. HLA type has been shown to be a variable in patients that's something that you cannot control. And then there are immune response traits that different patients have. I think that there are some patients that you could give all the factor in the world to in any sort of different situation and they will never develop an inhibitor. And then there are some patients whose immune response just seems to be primed to make an inhibitor. But what about the treatment variables, the things that we have at least some control over? The first is number and pattern of factor VIII exposures. And this is an area of great debate, as everyone knows. Is it the number of exposures? Is it the frequency of exposures? Is it the intensity of exposure? Or is it that these exposures often happen in the setting of a primed immune system, an infection, inflammation, surgery? These are all things that we simply don't know. And also, when it comes to picking up these inhibitors, it's the frequency of monitoring. If you're monitoring more frequently, you may pick up a low titer inhibitor, and Assad mentioned early on that this may be a transient inhibitor. So are those really important? Probably less important. but if you're monitoring more closely, you are going to pick those up. So we have lots of variables that are inherent to the patients and lots of variables inherent to the treatment of our patients. Next inhibitor, please, listen to me. So I wanted to mention a couple important publications that have come out within the last, I guess, 10 years now. So back in, let's see, when was Canal? 2007. The European group was looking at previously untreated patients with severe hemophilia A, and they recognized that risk of inhibitor development seemed lower with plasma-derived concentrates than with recombinant concentrates. It wasn't statistically significant, but they were seeing this trend. This study was not designed to randomize patients to different types of products. It was just whatever product the treater put those patients on, and they noticed this signal. So wanted to look at it more in depth. So in the Rodin study, they again looked at previously untreated patients with severe hemophilia A. This was 29 hemophilia treatment centers, mainly in Europe. And in this study, they were able to show that there seemed to be a second-generation recombinant product that seemed to be showing a higher risk of inhibitor development compared to a third-generation product. However, if you look at the timing of this study, you will see that it may have been the timing of giving these products to patients, because that particular second-generation product had come out with data recently that in their pivotal PUP trial, that rates of inhibitors were lower with that particular product. So it may have been that treaters were choosing that product thinking it had a lower risk of inhibitors and putting their highest risk patients on that product. So what we really needed was a prospective randomized controlled trial to look at this issue. And that's where SIPIT comes in. This study actually was a randomized controlled trial where patients were randomized to either a plasma-derived concentrate or a recombinant concentrate. And they did see a higher incidence of inhibitor development with recombinant products. That's all inhibitors, high titer and low titer, than they did for those that received plasma-derived products. Not nearly as big of a difference when you look at the total number of high titer inhibitor patients, but you're certainly having more low titer inhibitors in patients on the SIPIT trial. And then one trial that has been, I realize I had left off the reference for this one, the PUP-A-LONG trial. So this was using a lactate for previously untreated patients. It was not a randomized trial. It was a trial just patients that you wanted to start on a lactate and follow for inhibitor development. This data has been presented at EHAD. It will be presented at ISTH in a couple weeks. And we saw something very similar to what we've seen with every other product for hemophilia A. You have about a 30% risk of inhibitor development, but the risk of low titer inhibitors was only around 15%. And so I think that this is interesting data and encouraging that perhaps there may be an extended half-life product that might have a lower risk of high titer inhibitors. But again, I think the overall risk of inhibitors seems to be about the same. So what do you do in these situations? If it's a short-term situation where perhaps it's a low titer inhibitor, you can increase the dose and frequency of factor VIII if you have that available to you. You can go right to a bypassing agent if you have a patient who has a bleed that's not responding. Certainly in this patient, you want to do PRICE, so protect, rest, ice, compression, elevation. I think particularly in boys this age that present with knee bleeds, it's critically important that you try to get them off of this joint and protect this joint as much as possible. In the long term, still our best option is ITI. I think that even in the setting of the newer agents like emicizumab, it's important that patients still have tolerance to factor VIII if you can achieve that. Next slide, please. What are some of the data that suggest how likely you are to succeed with a patient? And I think this is critically important if you're dealing with constraint of resources. And the vast majority of this data comes from registry data. And historically, we were always taught that a peak historical titer less than 200 Bethesda units was a good prognostic feature. That a peak inhibitor titer during ITI that was less than 200 Bethesda units was a good prognostic feature. That the initial registry data, the North American registry, suggested that if you waited until the inhibitor titer was less than 10 before you started ITI, you would have better success. However, Dr. Shapiro and colleagues have some very nice data in the last few years that show that starting ITI perhaps earlier and not waiting for the Bethesda titer to fall to less than 10 gives you actually the best likelihood of success. It's also been thought that patients less than the age of 8 at the start of ITI did better. If you initiated ITI within 5 years of inhibitor diagnosis. And this last point under this, this category is interruptions in ITI less than 2 weeks in duration. This one I do believe, I think adherence to ITI regimens is extraordinarily important. So in my mind, I think that the age of the patient, the duration of the inhibitor is less important than getting this family into a situation where they can actually be adherent to the ITI regimen. You've heard me talk a little bit about epitope mapping. I think that that will be something that will likely inform our prognostication about who will respond to ITI in the future. And then Gilly Kennett in Israel is doing some really interesting work looking at cross-reactivity of factor VIII concentrates in vivo. So actually taking your patient's plasma and then trying different factor VIII products in vitro to see which product the patient has the most or least immune response to. So I think in the future, we'll be able to sort of prioritize patients who are most likely to respond to ITI and those that really may not ever respond to ITI. Next slide, please. I think that's it. So I'd love to take any questions.
Thank you, Amy. Asad, maybe
yes.
Take over that. Yeah.
Thank you very much, Amy. I see that we have a few questions that came through the chat, and one of them is really the ultimate question that everybody, whenever we talk about inhibitors, they ask, which is the effect of switching between products, either brands or categories between plasma-derived and recombinant. Would it induce more inhibitors, the switching between brands or categories?
That's a fantastic question. No one really knows the answer to that. I think the best data we can point to is in countries where they had wholesale switches based on tender programs. So this has happened in the UK, this has happened in Canada. And in those patient populations, they did not see increased risk of inhibitors with switching between products. But I do think that there may be a category of patients, particularly if their inhibitors are really targeted at that C2 region, who might do better on plasma-derived products. But again, it's a study that I just don't think that we will ever be able to do. And I think that, you know, if I were in a situation where I had complete control and unlimited resources, I think I would like to try to stick with one product. But I wouldn't have qualms about switching products if that's what I needed to do. So.
Thank you. And then, you know, also we always recommend that prophylaxis starts at a very early stage. So starting prophylaxis, low dose prophylaxis, particularly at early stage, do you think it will reduce the probability or possibility of developing inhibitors in the future?
Also a great question. So if you look at the joint outcome study, actually the patients who developed inhibitors were on the prophylaxis arm. So that would argue that maybe early prophylaxis doesn't necessarily protect against inhibitors. So I think it's a question that we just don't know the answer to. I would always prefer, if at all possible, though, to give factor VIII exposures with as few danger signals as possible. So I think having those first exposures be not associated with bleeds or surgery or infections would be helpful. Not a lot of data to prove that, but I just think we could try to manage all of those things that we do have control over. So having good IV access and the lowest number of danger signals that you can, I think is what I would try to do.
Oh, okay, so another here questions, and I'm very pleased that Dr. Valentino is back also. Questions regarding the exposure day, please, because we also hear a lot about the exposure day, just 20 exposure day, 50, 75, more than 100, up to 150. So in your opinion, what would be, let's say, the average or cutting point that, let's say, the inhibitor would be less possible after that cutting point?
So for me, the first time point that I'm really looking for is 20 exposures. Most high titer inhibitors will occur within those first 20 exposures. That happened in the CIPIT trial, that happened in the Eloctate pup trial. So I think that 20 is a good number. That's going to get you 80 to 90% of high titer inhibitors. Then once you get to 50 exposures, that's the next step when you know your heart rate can drop a little bit, your blood pressure can drop a little bit. That it's unlikely after 50 exposures. But you know, I think anyone who's been in this field long enough will still say, but I did have this one patient who had 149 exposures developed an inhibitor. But certainly 20 is the first goal in
yeah.
What about you, Len?
Yeah. I think that's pretty consistent with my experiences in the first 20 exposure days. I think that the other potential modifying factor is the family history of an inhibitor. And I've seen patients that are the second or third in a family to develop an inhibitor, and it seems that they will develop it certainly within that first 20 days and sometimes much earlier. So I think that is one factor that you could use if there's a family history of an inhibitor. I had one family with 5 boys with severe hemophilia A. 3 had high titer inhibitors, all occurring in the first 10 to 12 exposure days. So it does happen, and why the other 2 boys were spared from an inhibitor is totally unclear.
Yeah, I remember a case really which was presented by Manuel from Sick Kids also about two brothers. One developed high titer and the others didn't, and they said why this one did develop and the others nobody knows.
There's even the identical twin brothers from the Netherlands who one developed an inhibitor and one didn't. So there's clearly there's something that we don't understand.
Yeah, I think the Malmo inhibitor study showed a fair concordance between brother pairs, but it wasn't universal. So there's clearly other modifying factors and likely environmental factors that play a role.
Okay. So any questions again from the floor? Again, Novi, I know you have patients with inhibitors. Any comments or questions regarding your patients, please?
Probably not for now. Actually, we in Jakarta, we don't have experience in ITI for patient with inhibitor, and yeah.
Okay, thank you. Another questions to Amy also, because we always suggest that people, when they put patients on prophylaxis to let's say in the first 50 or 75 do periodic test of inhibitors. The countries, they don't have a lot of resources to do repeated tests. So what would be an ideal one for developing countries interval for testing inhibitors?
In terms of interval for testing, I will try to see all of my young patients under the age of 2 every 3 months. And if they have had factor VIII exposure between those 2 visits, I will test for an inhibitor at that time. I think if you don't have Bethesda titer testing, mixing studies would be your next best bet.
Yeah, okay. Ampaiwan, I know also you have good experience in this. So any comments from your side here?
It depends on, I have the same idea as Amy, that usually the high titer we found in the first 20 days. But for this side of the world, sometimes the monitor and the screening for antibody is lacking. And then some people said that using the cryoprecipitate, we have a less chance to develop antibody. I against this one, because here at Ramathipati Hospital, by the cross screening and monitor, we found 30% of severe hemophilia patients have antibody. So the first 20 days is the golden period. But after 150 days, they have lesser chance to develop antibody. That is my own experience.
Okay. Dr. Sofal, I know you are with us also, and we've seen together in Phnom Penh some patients with inhibitors. So from your side, do you have any comments also on this, particularly from the diagnostic side?
Oh, here we have some case only with the inhibitor, and we didn't find out for how long exposure days of the patient to the factor VIII recombinant or concentrate of fresh frozen plasma for the development of the inhibitor. We don't know. So we suspect and diagnose the inhibitor when the treatment or factor replacement therapy is not successful. That is the thing we are doing. Okay.
Okay, thank you. Jay, I think we're running out of time, so maybe we can move.
Yes. We just have one poll before this. We'll close it rather earlier, so Daniela, maybe you can close the poll at 1 minute instead of 1 minute and 30.
Yes, please.
Yes.
And Dr. Novi, as we're answering the poll, I've given you control, so please let me know if you can.
Jay, maybe you could ask also questions, I mean, not in a poll, because I think that we're gonna run beyond the 2 hours that we put. So are the people have time to go over this or not? Then we will have to reschedule or see how we're gonna do that.
Yes. I mean, we know that's the good and the bad. If the discussion is very stimulating, you will run over.
Yeah.
Yeah. Okay. Yeah. So for the poll results, not enough factor for our patients is the majority opinion with regards to the greatest challenge in hemophilia. Okay. We will proceed to the next country presentation by Dr. Novi. So Dr. Novi, if you can control your screen, please confirm. If not, I can move the slides for you.
Yes, I will try, Jason.
Go ahead.
I think I cannot move my slide.
Okay, then that is my job. I will move them for you.
Just go
Thank you.
with it always, Jay, then it's easier.
Go ahead. Go ahead.
Yeah, thank you. Yes, so good evening from Jakarta to everyone. Thank you for this great opportunity. So the case was a boy, 15 years old, with severe hemophilia A. Next slide, please. He came with chief complaints, more intense growing pain since 2 days prior to admission. Next, please. So the present illness, he was complaining about growing pains since 2 weeks prior to admission, and there was no improvement with administration of plasma-derived factor VIII as home treatment, and the pain was getting more intense in the last 2 days. No history of trauma, and at the time the patient was not able to walk, and he was most comfort with fetal position. Next. The previous history of this patient, he was diagnosed as severe hemophilia A since 6 months old with frequent mild bruises, never received any hemophilia factor, only doing rise. At 4 years old, he was suffered intracranial bleeding, and he was received factor VIII replacement therapy for the first time. And 4 years later, we found the occurrence of inhibitor of factor VIII with high titer, 20 Bettis day unit. And since then, the titer of inhibitor was ups and downs, and he was treated with on-demand with factor VIII, and sometimes also with bypassing agent, recombinant factor 7A, and he never underwent ITI. Next. So the physical examination at the time of admission, he was mild undernourished, moderately ill with severe pain, with the visual analog score 8 out of 10. And we found in the local assessment, there was a limited range of movements in the hip and right extremity, and hyperestasia in the right extremity. And we also found positive tenderness in the right inguinal region, but no palpable mass nor bruises. Next, please. So we performed ultrasound of abdominal pelvis, and we found a hypoechoiclation in the right inguinal region, medial to right arteriovenosus femoralis, suspect iliopsoas hematoma. This laboratory evaluation, actually the inhibitor titer is at the 2nd week of hospitalization. I will show you in the next few slides from the initial admission. Next slide, please. So here, what we find in the MRI of this patient, we find a huge intramuscular hematoma in the right iliopsoas muscle, extended to the caudal until the right inguinal region with a size 16.5 times 7.5 times 6 centimeters. Next slide, please. So here's, I want to show at the time of admission, the inhibitor titer was 4.8. And so we treat the patient with a high dose plasma-derived of factor VIII, while we still waiting for approval of recombinant factor 7A from the hospital and the insurance. And at the time, we also request the bypassing agent to the WFH. And we start to give this patient with methylprednisolone to eradicate the inhibitor, 1 milligram per kilogram body weight, and morphine for the pain. So 6 days later, we check again the inhibitor factor 8, and we found it decreasing to 2.4. So we decrease the dose of factor 8 and continue the methylprednisolone. But 5 days later, we found the spiking of the inhibitor factor 8 to 40 betas per unit. So we increase again the plasma-derived factor 8 dose and increase the dose of methylprednisolone to 2 milligram per kilogram body weight. And in a few days, this patient were lucky that the FEBA donation from humanitarian aid came, and then we can perform the surgery with the FEBA. And at the 8 days post-surgery, we can discharge the patient. And 2 weeks later, on the outpatient clinic visit, we evaluate the inhibitor was negative. Next slide, please. Here I want to show you the FEBA protocol that we use perioperative. So 1 hour prior to surgery, we give this patient 100 IU per kg. And then after surgery, we continue with 50 IU per kg. And total dose in this day of surgery, we give 200 IU per kg for this patient. And then we continue in day 1 to day 7 with 50 IU per kg every 12 hours. But we cannot give, next slide, please. Next slide, please. Yeah. Yeah, so, but we, yes, thank you. But we cannot continue the FEBA because the number is only sufficient for 7 days. So next slide, please. Yeah, here we see on day 3 post-surgery, the wound is very good. And at day 6, we see that it's already improving. And he was permitted to go home 8 days after surgery. And we continue with plasma-derived factor 8 for the next 7 days. And the methylprednisolone was continue for the next 7 days, but then tapering for 2 weeks. Yeah, I think this is the end of my presentation. Yeah, so for conclusion, the management of bleeding in severe hemophilia A with inhibitor factor 8 is very challenging. And since we cannot do the ITI for patient with inhibitor due to limited factor in our country, we use eradication of inhibitor using immunosuppressive agents that may be successful, and we see success in this patient. And more treatment options are needed for patients with inhibitor in developing countries. Thank you.
Over to you, Asad.
Thank you very much, Jay. It's really very interesting case. Thank you very much, Novi. I would just like to draw attention of our colleagues to the first photo that Dr. Novi showed, the position that the patient was taking while he was, when she took the photo. And this is usually the position that the patients will take if they have such kind of bleeding, because that is going to make them feel much better. So this is only what I wanted to draw your attention, because it's going to help you a little bit in the diagnosis if when the patient would come. And then I have another question. Maybe I will give this question also to Amy, because we talked about the immunosuppression with rituximab, but here also Novi used prednisolone. So in your opinion, also using steroids for controlling inhibitors. What's your experience in this?
I have limited experience. We have done it in a couple cases, particularly with intracranial hemorrhage in little guys who have not had 20 exposures yet. I have not done it in a case of a pseudotumor. I think it's fantastic that it worked. The thing that I would have worried about, would it have impaired wound healing? But it didn't appear to in this case. So I think this is a case where, you know, you've got talented hematologists who are there with the patient and can monitor them. So I think that this patient's outcome, good outcome, was really because they had such great attention paid to their hemostasis.
Okay, thank you. Len, any comment from your side on the steroids?
Yeah, again, I have used steroids in an ITI protocol, but I would be very careful in a post-surgical patient because of the risk for infection.
Okay, thank you very much. I know that Mai is still with us. So Dr. Mai, I know also you had some patients in the past with pseudotumors. So do you have any comment or any things to share with us? Remember, you need to unmute yourself, please. Oh, maybe she is not. So I'm gonna then ask Fleury. Fleury, we haven't heard from you, so can you please just give us a comment?
Yeah, yes, it's okay. Yes, I have some. Okay,
Yeah.
do you hear me?
Yeah, go ahead, Mai. Go ahead.
Yeah, I have some case with pseudotumor, with a not too big pseudotumor. We can make the surgery, but for some patient we cannot do, especially in pelvis. We have one patient died because he pseudotumor bleeding. And we think that if we follow the patient is closely, maybe we have more chance for surgery for the patient at the early period. Hello?
Yes, yes, we can hear you, man. Go ahead, please.
Yes.
Okay, thank you. Fleury, we saw together, as I remember, in Manila, 2 patients with large, huge pseudotumors. So could you please elaborate on this also?
Good evening, Dr. Assad. Yes, we have done a few surgeries on patients with pseudotumor, but not with inhibitors. We have not ventured on doing surgery on patients with inhibitors, especially in the absence of bypassing agents. And in a few patients whom we had surgery, it was successful with the minimum of factor replacement therapy. We did not actually aim to have 100% factor activity, but only between 60 to 80% in the first few days, and eventually decreasing it to around 50 or 40% in the latter half of the first week, and then around 30-40% in the second week. And they recovered fully from the surgery.
Thank you very much. I know Dr. Aya left us, but Dr. U is still with us. So maybe, Jay, are we going to move to the next presentation?
He's presenting for Myanmar for us.
Okay.
Yeah.
Good.
Yep.
Yes. Could you move the slide, please?
Sure.
Yeah. Thank you. Good morning from, good evening from Myanmar. 21-year-old May was admitted to Yangon Children's Hospital on December 2016 for left thigh swelling and cannot walk well for 3 weeks. He got left thigh swelling off and on within 7 months before admission, and there was no history of injury to this thigh. Next slide. Regarding past medical history, he was diagnosed as severe hemophilia A, At the age of 2 years, as he got right knee joint swelling due to fall, he was regularly transfused blood products 3 or 4 monthly up to 12 years of age. After that, he lost our follow-up for 4 years due to social problem. During this period, he got repeated attack of joint swelling, but he took traditional medicine only. Next slide, please. This is the local examination of that patient. Left thigh was markedly increased in size compared to right thigh, and no signs of inflammation. There was fixed flex deformity of left leg. All peripheral pulses were intact. Right thigh was atrophy. We did X-ray thigh. We can clearly see pseudotumor of left femur. Next slide, please. Next slide. Yes. So he was given Elodate 3000 IU daily for 1 week, and ice packing and bed rest was 10. Next, please. Then we consult with orthopedic team, and they decided to do amputation. So we explained the condition to the patients and family, but they didn't give consent to amputate. Then he discharged from hospital, and he was given Elodate 10 IU per kg 3 times a week at home for 1 year. Within 1 year period, his swelling was reduced in size, and he can walk with walker. We also check inhibitor level 3 monthly during 1 year period. Although his inhibitor status was low responder, we only continue prophylaxis dose for this patient at home. Unfortunately, his regularly checked hepatitis C virus infection was positive, and he was given treatment for 3 months till seroconversion. Next slide, please. 1 year later, he readmitted to hospital with severe pallor and left thigh swelling. Next, please. At that time, he was in severe pain, severe pallor, and shock. Left thigh was increased in size than previous one. Next slide, please. So you can see large left thigh swelling than the previous time, and we did X-ray again. Next slide, please. So we resuscitated with IV fluid and Paxil 2 units. Then we give the Elodate 3000 IU and IV tranexamic acid 8 hourly daily for 1 week. Next, please. 1 week after stabilization, we consult again with orthopedic team, and they decided to do operation. 3 episodes of bleeding into pseudosis occur while consideration for amputation by patients and family, but we could control it medically. Finally, they agree for amputation. Next, please. Before operation, we prepare him to fit for operation. He was given IV tranexamic acid, IV antibiotics. Total 5 units of Paxil was transfused. On November 2019, above knee amputation was 10 and the cover of clotting factor concentrate 100%. Biopsy results was chronic non-specific inflammation with granulation tissue. Next, please. During operation, he was given Elodate 3000 IU 1 hour before operation and 8 hours after operation. Then we followed, he was given IV clotting factor concentrate 3000 IU daily for 7 days and IV antibiotics and IV tranexamic acid. Next, please. This is the 7th post-op day of condition. Next, please. Now he is on prophylaxis 10 IU per kg 2 times a week. Next. Thank you so much.
Tad, over to you.
Thank you, Jay. And thank you, Dr. Wu, for this, very nice presentation, and very interesting case. What I'm really, I would like to ask our panelists, because even from the first X-ray that we saw, there was already some bone tissue destruction. So from the first one, this was a little bit, let's say, late in diagnosing or doing the X-ray. And my questions to first, how can we capture these before the bone tissue inclusion so we can reserve the limb?
Yes, yes. He cannot. He is a survivor of Nage. This is the largest storm in Myanmar. So there was a problem to come to hospital. So he came back to our hospital very lately, and he didn't consent. He didn't give consent to amputate.
Yeah.
I think these cases of pseudotumors are incredibly challenging, and they can present in many different ways. And so I think the best way to find them is, of course, if you can see these patients as frequently as possible. And I know that that's really challenging, particularly in large countries, and that where transportation can be a challenge. We have been doing more and more with video medicine in light of coronavirus, and I have been pleasantly surprised by how much I can see of the patients, and then also even get to see their gait and some physical activity by video telemedicine. And I wonder if there may be opportunities, if you can't see the patient in person, at least to set up some video telemedicine. And the physical therapists in the United States got together very quickly when coronavirus hit and came up with some really nice guidelines of how to do a physical therapy assessment in via telemedicine, which I'm sure we could provide to Assad and to anyone here if they're interested. I also wanted to mention that two other points. I think that vitamin D levels can be incredibly important in patients with hemophilia. They tend to have low bone density baseline in many cases, particularly if you also have hepatitis C. So I think vitamin D supplementation may be helpful. This case might have been too far gone for that. And then the last thing I wanted to mention is the potential of radiation therapy for pseudotumors like this could perhaps be helpful.
Yeah.
Yes, thank you so much for your suggestion.
That was one of the questions from the floor about the low dose radiation for that. So yeah, there was a question asking about what would be the role of low dose radiation in pseudotumor. So is it gonna reduce the bleeding during the surgery or control the bleeding after for the low dose radiation? Amy, it's the question.
I think it could be both. You know, there are not a lot of cases of radiation use in younger children. Most of the cases that I've seen, or case reports or series that I've seen, have been in older patients, because I think we're more reluctant to radiate children. But I think if it's between radiation or amputation, I think I would try radiation first. But I think it's going to reduce the swelling and hopefully also the bleeding during a surgery.
Okay, thank you.
Thank you.
I don't know if Glenn has more experience with radiation or not.
Yeah, I think the role of the radiation therapy is an effort to induce apoptosis of the blood vessels. And the hypothesis always has been that by providing low dose radiation, you can sort of devascularize the hemophilic pseudotumor capsule. And I think that there's some reasonable evidence that suggests that that's a way to approach it, especially if it's early on when there isn't bone destruction. I think a really excellent review, I'll put the reference on the chat, is by Rodriguez Merchan just this year, a review of hemophilic pseudotumors, diagnosis and management. And it's really a very nice review article that goes through not only the diagnosis, but minimally invasive types of procedures like percutaneous drainage, but then also surgical procedures and includes radiation.
You had a book jointly edited between you and Carlos, I think, right, Len?
Yes. Yeah. Yeah. So I managed a number of hemophilic pseudotumors. The first one was with Uri Martinowitz many years ago, a giant pelvic pseudotumor that we were actually able to save both limbs as well as provide this man an excellent quality of life.
Okay, great.
Yes, thank you.
Thank you, Dr. Wu. So, Jay, I think again, for the sake of time, we don't want to stay longer. So that's, I think, our last case, right?
I'd like to apologize for the time constraints, again, because there's a lot of stimulating discussion. But last but not the least, we have our doctor from Cambodia, Dr. Sofal, to present the last country case.
Tell me.
I can move the slides for you, Sofal. Go ahead, Sofal.
You need to move to the next slide.
Okay, so yeah, internet here.
Yes, go ahead, Sofal.
We can hear you, Sofal, so please start your presentation.
Sorry, the internet interrupt. Yeah, very briefly, I would like to present a case with factor 13 deficiency. There's only one case in my department since a long time. So Jason can move for me. The patient's 30 years old, man, since 10 years old, he had a recurrent deep muscles hematoma of right thighs, and he had undergone multiple operations without correct diagnosis in that time since he was 10 years old. And in February 2009, the first episode of spontaneous intracranial hemorrhage. Okay, next slide. The family history is that the parents are second cousins and no histories with the bleeding disorder. The hemostatic testing in February 2009, the bleeding times normal, PT, APTT normal, and fibrinogen slightly decreased 1.7 gram per liter. Erythrocysteine cofactor activity 96%, and the test for factor 13, the factor assay show less than 5% activity. Next slide. Since then, since the 20 July 2009, he is diagnosed with the factor 13 deficiency less than 5%. The complications occurring during the multiple hematoma of his thigh is multiple scar, and the right thigh with patellar retractions causing the non-flexible of knee joint. Next slide. The present illness on the 8th June last month, the second episode of a spontaneous intracranial hemorrhage occurred by spontaneous severe headache and vomiting with normal consciousness at arrival. Cerebral CT scans, intracranial hemorrhage, and this is the second episode, as I mentioned. And so we did